Patient assessment is a dynamic, hands-on process. In previous lessons, we have demonstrated physical exams that focus on one specific area of the body, but a focused exam is not appropriate for every patient. So, who should receive a full head-to-toe assessment? Trauma patients who have experienced a significant mechanism of injury, patients with distracting injuries, patients who are intoxicated or under the influence of any kind, patients who are disoriented, unable to recall what happened, or are suspected of being inaccurate historians for any reason, unresponsive trauma patients, and unresponsive medical patients with an unwitnessed or unknown chief complaint. Some parts of our assessment remain unchanged regardless of the type of call that we are responding to, like our scene size up. Our primary assessment can change up a little bit with trauma patients. If you note signs of obvious hemorrhaging in your patient that need to be addressed first, this means adding an additional step to our typical ABC primary assessment. This additional step is called exsanguination and is referred to as the letter X. After handling all obvious life threats, you should progress to your head-to-toe assessment in order to gauge the extent of the patient's injuries. This should be done on scene before moving the patient. During our head-to-toe assessment, we are looking for a wide variety of potential injuries. The best way to remember them all is with DCAP-BTLS, which stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. As the name implies, I am going to start my assessment at the head. I'm palpating the cranium, looking for any signs of DCAP-BTLS. I will run my fingers through the patient's hair and then look at my gloves to see if there are any traces of blood. I will palpate all of the facial bones, assessing the patient's pupils, and looking for bruising under the eyes known as raccoon eyes. Raccoon eyes are one of the signs that indicate that a patient has sustained a basilar skull fracture, which is a fracture at the base of the skull where the brain sits. Additional signs of a basilar skull fracture include crescent-shaped bruising behind the ears, known as Battle's signs, and the presence of blood or clear fluid leaking from the patient's nose or ear canals. If the patient has blood or clear fluid leaking from the nose or ear canals, I'm going to perform a halo test to determine if cerebrospinal fluid is present. To perform a halo test, simply take a clean 4x4 gauze pad and dab at the fluid. Cerebrospinal fluid has a thinner consistency than blood, so it will wick its way further into the gauze, creating the halo effect. Continuing the assessment of my patient's face, I will look into the patient's mouth to visualize the airway and inspect it for any blood or broken teeth. I will also take note of any strange odors, like alcohol, or the sickly sweet smell associated with diabetic ketoacidosis. I will work my way down the patient's neck, looking for any jugular vein distension or tracheal deviation. I will keep an eye out for any medical alert jewelry and take note if my patient has a stoma. Then I will move to the back of the neck, palpating the cervical spine to check for step-off. From there, I will palpate the scapula and the top of the shoulders. At this point, I can apply a cervical collar if indicated. I will begin assessing the chest by splitting the patient's sternum and palpating the clavicles. I will palpate the superior ribs under the patient's armpit and the inferior ribs. I'm going to pause for a second here to feel for equal rise and fall of the chest wall. Then I will listen to lung sounds. In addition to DCAP-BTLS, I'm going to check the chest for crepitus and paradoxical motion that could indicate a flail segment. As I palpate all 4 quadrants of the abdomen, I'm looking for a few more things in addition to my DCAP-BTLS. I will take note of any pain on palpation, rebound pain, distension, or rigidity. Keep in mind that if a patient is complaining of pain in a specific quadrant, we want to palpate that quadrant last. That way, it doesn't mask a lesser pain response in any of the other quadrants. I will assess the pelvis by pushing both sides inwards. If it does not elicit a pain response, and I don't feel any instability, then I will push downward. I will place one hand across the patient's pubic bone and press down, checking for instability. In the genital region, I am looking for any blood around the opening of the urethra, which indicates intra-abdominal hemorrhage with bladder involvement or kidney damage. I am also looking for any signs of urinary or fecal incontinence and priapism in males, which would make me suspect a spinal cord injury. Using the butterfly technique, I will palpate each of the lower extremities, checking for pedal pulses when I arrive at each foot. If the patient is conscious, I will check for sensory function by asking the patient to tell me where on their foot I am touching. If there are no obvious injuries to either extremity, I will check for motor function and equality of strength at the same time by asking the patient to push their feet down onto my palms like a gas pedal, then upwards towards their nose. If there are obvious injuries to an extremity, do not ask the patient to move that extremity. You will not be able to test for equality of strength. If prudent, you can assess for motor function by asking the patient to try wiggling their toes, since that requires minimal muscle movement. I will repeat this process with the upper extremities, testing equality of strength by asking the patient to squeeze my hands, if applicable. The last assessment area is the posterior side of the patient, and in order to do so, you must log roll the patient. If you are planning to place the patient on a longboard, try to have it ready in order to avoid unnecessary additional movement of the patient later on. I'm going to palpate the rest of the spine and posterior ribs, as well as listen to lung sounds. I will visually inspect the buttocks area for bleeding, which could indicate intra-abdominal hemorrhage. Finally, I will check the back of the thighs and calves for any decap BTLS. If my patient is unconscious, I will quickly attempt to collect a sample history from any friends or family that may be on scene while packaging my patient for transport. While en route to the trauma center, I will reassess my patient every 5 minutes by repeating my primary assessment, taking vital signs, and checking my interventions. I will also take the time, if possible, to treat any serious but non-life-threatening injuries that did not necessitate immediate intervention on scene. If you are unable to complete this step due to time restraints, that is okay. Your priority should be maintaining your patient's ABCs and frequent reassessment.